All right, well, let's get to the final parts here. Any particular case or patient from your career that stands out? Anything?
I wish I had kept a better record. Early on, I wrote down every case I did, then I quit.
Did you?
And it's funny, cleaning out my desk when I retired, I found all sorts of, pictures and things. And I thought, wow, did I do that?
That's funny.
You had some people with some significant deformities that you had to correct before you could put a joint replacement in. Those were challenging and very rewarding when you could do things like that. And so, yeah, you remember those kind of cases.
Nice.
And then you remember the ones that had problems and, they just killed you. But overall, I think hit more home runs than
you
strikeouts.
did strikeouts. I feel like that is the definition of a successful career. I agree. All right, if you could change one thing about knee replacements, like meaning these new surgeons that are coming out, maybe what they're being taught or how they're learning these techniques or approaches, is there you're like, why has this not already been done? Is there anything that stands out?
I don't know that I have any great thoughts about that. I think, the techniques continue to evolve. The ability to put them in well continues to evolve. I think things are heading in the right direction. Again, the real problem is that I've seen some projections where in the next 20 years, we're getting an aging population, we may be doing 650,000 knee replacements a year versus 300 when I first started, and who's paying for all that? Well, insurance and a lot of Medicare. And so everybody's looking at cost.
Yeah, they are.
Everybody, the government, us, hospitals, so there's got this tension between new technology, which costs money, and who's going to pay for it.
Mm-hmm. As the volume, which I feel like as long as I've known you, you've, you don't, I feel like you really separate the finance part of it, but I've been doing a deep dive into knee replacements and the financial part of it.
Yeah.
And the volume, like you said, is increasing literally by 300% over the next decade. And insurances just can't sustain it, right? So this is why there's pushes coming down to lowered reimbursement, faster, more ambulatory surgeries, outpatient surgeries, less hospital stays, less post-op PT, less, all these things. You're getting rewarded for improved patient outcomes and less complications, which is not a bad thing, by the way. But again, how they do it, I don't always agree. Why they do it, I understand.
Yeah. There was a point where we participated in what was called a bundled care program.
Yeah, I remember bundled. Mm-hmm.
And it sort of drove us crazy, but because you were rewarded if you did a better job, but some of the things that made it a better job where we really didn't have control over. Anything that we have control over, we're willing to take the risk.
Mm-hmm.
But there are just certain things that we can't control. Mm-hmm. And it was a little bit, what it ended up doing is it made you avoid certain patients because they were higher risk.
Right.
And which gets into a long
and you would
discussion.
lose money. You would lose money on taking the higher risk patient with the way you were getting reimbursed.
And so your incentive was not to operate on a higher risk patient. Mm-hmm. And you don't want to operate on a higher risk patient just to get the money. That's crazy. You want the good result, but it made it difficult. Correct. Because you were turning people away that you normally felt comfortable doing, but you didn't want to do it because it was going to cost you. Mm-hmm. And why should I take that risk? And it gets down to comorbidities, medical condition, but it got down to a lot of socioeconomic, because people need to have the ability to be cared for after surgery. Mm-hmm. And if they've got nobody at home and they're going to perhaps need to go to a rehab unit, well, guess what? That came out of my pocket.
Yes.
Well, that's not fair. Right. So my incentive was, you can't have surgery till you figure out how you're going to get yourself taken care of.
Yeah. Listen, and I want to say, this is, people think, healthcare is not a business, but it is a business in the United States. And I will say that part of I haven't mentioned it yet, but I developed a home program, and I developed a device. And actually, it was during the peak of the bundled joint program, because what I learned was, and again, for people listening, all they need to know is you got paid a lump sum to take care of this patient, and everything you did for that patient was deducted from this lump sum that you were paid. So whether the surgery, the OR, the all the things, the implant design, everything, but also the post-op therapy came out of this lump sum amount. So what I was seeing as a PT was some surgeons thought that the response to that was, let's minimize the amount of PT because it was a cost coming out of the lump sum that they had been paid. So it was a cost they actually had control over. So they were reducing PT. So some PTs were crying and bickering about not getting their knee replacement patients or not getting enough visits with them or treatments or whatever. I decided I was going to create something that, if I only got a patient once, twice, 4 visits, 6 visits, whatever. I mean, we used to get them for 16 to 18 visits. We were getting them for less. So I was like, I'm going to build something and create something so that the surgeons will still send them to me, knowing that I'm not going to give them 18 visits of therapy that's going to come out of their profit. So to me, it's like, it made me come up with a better home program that I really had no incentive to come up with before, because I loved seeing my knee patients.
Right.
They were great. They were easy. So I want to say sometimes good things come from really terrible changes, but it made me realize, okay, I don't know if this next patient's going to have 12 visits or 2 visits.
Right.
So if I know that, I'm going to have a sense of urgency when I treat them. And I think that urgency is good for the patient. But I didn't really have the light under my, there was no fire for me to do better.
Right. And the upside of the bundle care thing is it made us, and we're sensitive to cost. I mean, it's important to us to reduce the overall cost. It made us look at everything we're doing. And at the same time, you can't shortchange the patient.
No, that's right.
And therapy was a big component of it, because we send people to therapy and it they went in the black hole of therapy and what's going on, and did they, and all of a sudden, do we really need 6 weeks? Do we need less? Do we need more? I mean, what does it take? And so that's not a bad thing.
It's not.
And
it's not. No.
So
it made me realize if the doctor was giving me, say, they used to write 2 times a week for 4 weeks or whatever. And I started asking hey, instead of writing 2 times a week for 4 weeks or 6 weeks, could you just write the number of visits so that I could spread it out based on the patient need, right? Because sometimes they didn't need it in the first 4 to 6 weeks, maybe. So it made me realize that there is a better way for the patient. It needs to be individualized. And what I learned was the faster I got a patient to their dream outcome, the patient was happier. And if I could do it in the least amount of visits, the surgeon was happy and the patient was happy, right? So again, some changes come down and we complain, but it's a business. Healthcare is a business. And sometimes it makes us get out of our comfort zone and figure out a different way to do things.
We're all trying to build a better mousetrap.
We are.
And we're all trying to, that's everybody's incentive. But when you're dealing with people,
it's hard.
There's variability, and that's what makes this challenging.
It does. It does.
Anyway,
I'm going to say fascinating.
Or interesting.
Yes, very interesting.
Yeah.
Okay, let's go. A couple more. Now that you're retired, is there any perspective that has changed on healthcare? Like as you're looking back and you're out of it, and you're like, oh, is it for example, for me over my career, I have just the significant healthcare changes, the reimbursement changes, the coverage changes per diagnosis, especially for knee replacements. There's been a huge transition. And like I said, I'm not saying it's all good and I'm not saying it's all bad, but I'm saying it is what it is. And I am, proud of how I have been adapting based on what the patient can and cannot afford or can do. But is there any part of healthcare that now that you're out of it, that you're like, how we treat chronic knee OA and knee replacements?
Well, I mean, we were always sensitive to patients' needs and their situation or socioeconomic or whatever. But what I don't miss that frustrated me and a lot of my partners is the second guessing by insurers. We were questioned every time you made a decision. You were questioned as to whether or not this was a legitimate decision, and the criteria would change. You learn to dictate in your office notes certain bullet points because the insurance companies had a little list of check, check, check. And if you didn't put it in there, then they would come back for a silly reason to deny your coverage and that kind of stuff. It's like,
I feel like that's getting worse, not
yeah,
getting better.
it's gotten. I mean, I don't miss that at all.
Yeah.
And
yeah, I agree.
that was a huge hassle.
Yeah, same in therapy. We had to document skilled services, and if you couldn't document those keywords that justified why a patient needed to continue, they'd be denied. Yeah, I get it. All right, so if you have chronic knee osteoarthritis?
I do have a little knee arthritis, sadly.
Okay.
I never thought this would happen to me, but
I mean,
payback.
I feel like, it's like a car. No, it doesn't matter how good you take care of that car. It's still its age, right? So since you have a little bit of knee osteoarthritis, what do you do as a retired knee replacement surgeon who has seen all the gamut for the last 30 some years? What do you do, or what are you even thinking about your knee?
Well, the first thing you do is you need to watch your weight. Some of us are better than others, but I used to use the analogy of you're 30, 40 pounds overweight. I mean, would you walk around every day with 30, 40-pound backpack on your back? What do you think that's doing to your knees? And anyway,
that's true.
And that's a tricky subject to broach, but
I know. But it is a non-surgical approach.
Absolutely. And then there's exercise. And there's a ton of good data out there that appropriate exercise, strengthening balance, is absolutely helpful for an arthritic knee. It's very interesting. People would come in and go, well, can I do this? Can I walk? Can I do this? And I go, well, a lot of it is sort of what you just got to figure out what works for you.
Right.
And as a rule, the more impact exercise with a bad joint, the more pain you're going to have. So yeah, people pretty quickly learn to figure out what works and what doesn't. Some people can walk, some people can't. Some people can walk a certain amount. But exercise, the correct type of exercise, is huge.
He might be called into surgery.
I'm
but
really
can't
sorry.
Because he's retired. So this cannot be a surgical call.
I forgot to turn off my phone. I am terribly sorry.
No. We're almost done.
Sorry about that. It's the car dealer.
Yeah, that's right. Good.
Sorry.
Perfect.
I'm so sorry.
No.
Exercise is I think a key component for strengthening, et cetera, for a bad knee. It's sort of multifactorial. Medications, anti-inflammatory meds, they may help up to a point. Injections in certain situations used judiciously can be very helpful. Steroids, we have an anti-inflammatory drug that will sometimes inject in a knee, Toradol. The other type of injections, the visco supplementation, the gel shots or the chicken shots, rooster comb. Yeah, there are patients that will tell you they got a great result. If you really look at the statistics, that stuff's pretty worthless. And it's highly marketed, it's highly pushed. And if patients really want them, I would sometimes do it, but I think they're overall pretty useless. Diet supplements, same thing. Glucosamine, chondroitin. I mean, they're not regulated by the FDA or any governing body. I mean, what are you really getting? I mean, there are people that will tell you to help fine. I mean, you go to Costco and there's aisles full of this stuff. So, and because arthritis is so prevalent, people want to try it for a while and they like it, fine. But yeah, an occasional injection, just different things that you do. Sometimes tend to wax and wane a lot, and where some days are great and you think you're better, and then other days are not. Some of that may be due to what you did the day before. A lot of wordy question to your answer.
No, I love it. I mean, you touched on everything
but it's a condition you learn to live with till you decide that this isn't working for me, and then that's when you
Got it.
take the next step.
Well, and again, for people listening, I've had three knee surgeries. So again, I'm aware that I'm a candidate of someone who might need a knee replacement.
You're at risk. Yeah,
I am at risk, right? But I mean, I'm like you. I'm like aware of keeping a steady weight. I can tell when I've gained a few pounds, and whatever. I play competitive pickleball, so I do an exercise program to make sure my range of motion is good and my strength is good. Glutes are also a big component of knee pain. They help. And then I will dabble in topical anti-inflammatories every now and then, just to be like, if I feel something. I do use ice if I've done an aggressive pickleball workout and I really felt wherever I feel it, I might use ice for kind of just that pain control if I have some. I've dabbled in an anti-inflammatory oral when I've had an actual injury that it's lasting longer than I need to. I have not had to do any kind of injections or anything major like that, but I mean, that's how I am managing it. So
exactly, it's just basically symptom management. It's symptom management, and it's a little of trial and error of this and that. I think, and I would always make a point to tell people that taking oral medications, you shouldn't really take anything unless you're absolutely sure that you're getting a benefit.
Right.
And there are a lot of side effects to nonsteroidal anti-inflammatory drugs, of which you can buy over the counter, naproxen and ibuprofen. They are not benign drugs.
Correct.
And used correctly, they can be helpful, but you need to know what you're doing.
I wrote a blog about oral versus topical. And that's why I did a deep dive into topical, and I was like, if you can get that.
And those are available. People, for a while, everybody was on this huge CBD kick. I've got a friend who she's got rheumatoid arthritis. She swears by it. She gave me some. I didn't think it did one bit of good, but
I think it's trial and error.
Things you can try. I mean, as long as you're not doing something harmful.
Correct.
And
correct. And my one tidbit to add about his chondroitin as a glucosamine, also, like I said, I'm the same way. It's not regulated. Some products have better quality ingredients than others. How do you figure that out? It's a whole thing. It's not just, I went and tried it. I bought it from a grocery store. I tried it. It didn't work. Believe people when they say it works. It works for some. It doesn't work for some. It all depends.
Yeah, I think there is some agency that looks into supplements. I don't know enough about that, but
there is one. And what I learned, the take-home point is all supplements are not created equal.
Right. Yeah.
And you have to do a lot of research to find out which ones actually have true ingredients to have the benefits.
If people wanted to try them, I would not oppose. I mean, it'd be fine. But
you have an opinion on stem cell?
Stem cells are fascinating. I think it's going to be amazing what comes out of this. As of right now, there's no utility for stem cell injections for arthritis. I did leave out platelet-rich plasma injections, which kind of gets back to stem cells. So platelet-rich plasma is where we draw blood, spin down in a centrifuge, and you get a plasma. Platelets have a lot of growth factors in it. Well, stem cells have some growth factors too. So can you perhaps get a benefit from a stem cell injection where your knee feels better? Yeah, you could. Are you growing cartilage? No, absolutely not. And that's just snake oil. But the platelet-rich plasma is pretty interesting. It's still pretty much investigational as far as insurance companies are concerned. They're not going to pay for it. It's expensive. The actual little centrifuge tubes are like, I think, $300 or $400 each. So most people, I think, charge $500 a shot, I think. And you may need 3 of them, and they may not do one bit of good. But it's not a fix. It's just a temporary fix if it does anything at all. So, but the stem cells, that's ridiculous.
Oh, it's
I'm just going to put it right out
there.
It's
booming.
It's ridiculous. Well, I mean, again, you're desperate. You don't want to have an operation. But I've seen patients that spent $5,000 to $8,000 on stem cells. It's just, that's robbery.
So I think you've answered. My last question was going to be, what do you see the future of knee replacement? Like, you're now going to sit on the sidelines, you're going to watch it. You kind of alluded to robotics and, implant change. I mean, they just keep on.
I'm sure the material technologies will continue to improve. Everybody talks about nanotechnology, which I can't really begin to expound on that, but it all has to do with materials and biocompatibility, and you make parts that work better and function better. The one thing that I have read a little bit about that I think is could be huge. One of the worst, the worst complication short of death of a knee replacement is an infection.
Yeah,
it's a disaster. It's horrible. It's rare, but it's a disaster. And nanotechnology has perhaps at some point the ability to create some sort of coating on the components that will make them more resistant to bacteria.
Oh.
And the problem with an infection with a joint replacement is bacteria can secrete what's called a biofilm, where the bacteria stick to the components, and antibiotics cannot penetrate that biofilm. So you can pump somebody full of antibiotics all day long, but you cannot eliminate bacteria stuck to the metal.
So that's when they remove the
And
compartments.
that's why you have to take the knee
put the
out.
spacer in.
And it's a huge deal. It's a gigantic deal. And if we can help prevent infections, and there's a lot of things that we've done over the years that we're super strict about. But if we can take that a step further, or we can prevent the need to remove an implant for an infection, that's going to be Nobel Prize winning technology, I think.
That's great. That's great.
So,
okay. And then I'm going to end with two fun questions.
Okay.
Two fun questions. The perception of some other healthcare professionals is that orthopedic surgeons have big egos. And that we can't, suggest anything. We can't talk to them anything because they are the be all end all. I feel like Dr. Shell, for the record, is not this person. He has never been this person since I've had any interaction with him, nor any patient that has talked to me about him. He's the most, just no ego, chill, will talk to anybody. But this is the perception of orthopedic surgeons.
I'm sure those folks are out there. I mean, first of all, to be a surgeon, you tend to have a lot of self-confidence. You just do. You're going to put somebody to sleep and make a big incision on them and do all this stuff. I mean, the things that we do, if you move that scenario 200 yards away out in the parking lot, we'd all go to prison, right? I mean, so just joking. So, I mean, I think a lot of us you have to have a lot of confidence. At the same time, if you've got a gigantic ego, think you can do no wrong, you're a dangerous person. But I don't know. I guess there's doctors on the whole are probably not the easiest group of people to manage. It's been called like, trying to herd a cat or something. It just doesn't work. So, but that's just goes with the business, I guess.
I had to ask that one because people said if you have a surgeon in front of you, you got to tell them that. Because I'll tell you, as a physical therapist who has, like I said, I study, I research, I do whatever, and I just want to build rapport with whoever I work with, and I don't want to think about. You called it self-confidence, and again, self-confidence is one thing, but to someone who won't listen on a topic that may not be their expertise, right? Like I have rehabilitated thousands of knees, and I would say you have performed thousands of knee replacement surgeries, but how many have you rehabilitated from the day after surgery until their dream outcome, right?
Yeah.
And so to me, that's my expertise. And you and I had talked about this before we got on camera about just the relationship between the treating physical therapist to your knee replacement patient that you did surgery on. There's not a lot. You kind of send them to us into the, like you call the abyss of PT.
I sort of alluded to the black hole. That because you have so many groups of therapists around town, and patients live here and they live there and they want to stay close to home, and I get all that, but it is a little bit unnerving for us to just send people off and we're not really quite sure what's happening.
Right.
And we're very dependent on the people we work with, whether it's the nurses in the hospital, your OR staff, your physical therapy staff. If they don't do a good job, I'm going to get a bad result. Correct. And so, we're very dependent on that.
And I think that would be my answer to the question of what's the future of knee replacements. I would love for there to be just an open rapport between the treating therapist and the surgeon for the number one reason that we both share, which is we want the best possible outcome for the patient.
And you know, for a lot of us, we would have a pretty core group of therapists that we worked with and we knew, and they would visit every now and then, and we'd talk. Communication could always be better, but the therapist would send me notes, or they, you know, and I read all that stuff. I mean,
I think that's you though. That's you too.
Well, I mean, you make your own assessment, but you're also looking at what's presented to you.
All right, so here's my last question.
Okay.
Orthopedic surgeons, you put a whole bunch in a room together. Is it like uber competitive? Is it like I have I don't want to share my secret sauce of what's working?
No.
Again, I feel like I'm asking the wrong person, but you're like, no. All, what do you call it? Rising tides raise all ships or something?
Yeah, rising tide floats all boats or something. Anyway, I mean, you know, I was part of a big group. We like talking to each other, like, what are you doing, and what do you think about this? Or somebody would have this idea. You go to a meeting, come back with another idea, and that was good. There's always, you know, cross-town rivalries where, you know, people think I'm better than you. Okay, whatever, you know, but
so within your own practice.
But within our own practice, no, there was a lot of idea sharing, and you know, you're trying to build the best mousetrap, right? And so, if you can do it as a group, that makes good sense. You shouldn't be out there on an island.
No, I agree. Because, like you said, patience. We want to whatever's working for one, let's share.
And for those of us, you know, that work together, we also tend to work in the same facility, so we put our heads together and like, what can we do to make things better? What can we do to reduce these costs? And what's the best practice? And everybody's searching for the best practice.
Agreed.
Just as you are.
I am.
Yeah, the best practice.
Right. What is the best thing for to get the patient the best outcome? What does that look like?
That's what we're all after.
Yeah, I agree. All right. Well, that was it. The only other question I had, I'm going to ask him off camera, which is, who does he recommend, you know, do my knee surgery? No, I'm just kidding. I'm just kidding. I mean, no. Is there anything that you feel like, you know, a patient who is waiting to have knee replacement surgery or thinks they need it or has been told they need it, is there anything that we didn't touch on today that you think they need to hear?
Well, you know, you didn't ask about preoperative physical therapy or so-called prehab.
I didn't.
And
my specialty, though.
which I like, and the concept is great. It kind of went away as a cost issue.
It did.
And that was the driving. But let me tell you, patients that understand their exercise routine pre-op that they're going to be doing post-op, I think it makes a world of difference.
You know what? I'm just going to say thank you for mentioning that.
So when they show up for their first post-op physical therapy visit, not having a clue what's getting ready to happen.
Yeah. No.
An informed patient is a better patient.
Yes. And I will elaborate. He's right. It used to be joint camps, pre-joint camps, prehab things, because it was covered.
Yeah.
And once it became not covered, it kind of fizzled out because it wasn't a reimbursable thing. And then it was kind of left to the PTs, but the PTs weren't really doing it. And then, you know, patients given a packet with a bunch of information they have to read. The exercises are in there. Yeah. So I will say, this is my one and only plug. I created a program that I want the patient to use 4 to 6 weeks before surgery, not just to stretch the knee, strengthen the knee, do whatever. It does all those things, but it's to make them familiar with the exercises that is expected from their leg the day after surgery when there might be pain and swelling. And I agree, the outcomes that I have seen are far superior than whenever I treated them in inpatient rehab. I am seeing range of motion gains that I have never seen before.
I think the understanding of your exercise program beforehand makes a huge difference afterwards. Whether or not you're improving motion or building strength, I don't think that probably makes any difference because it takes so long to do that. I don't think it makes any difference, but
it's more just preparing the knee for something that it has not been doing, so that when it does have surgery, it's ready to do it. It's also, to me, I'm not going to bore these people, but there's a neurological component to knee replacement recovery because every knee replacement patient's had chronic knee pain. It's not like they had pain for a week. They've had pain for months, years, usually decades. And there's a neurological component to chronic pain. And so the brain has it's hypersensitive to anything you do with that leg. And therefore your pain goes, the rating is higher for patients simply because the brain's like, whoa, I'm not sure if we're going to like this. So part of the Prehab program that I created was to retrain and start preparing the brain to not be so hypersensitive, to desensitize it so that when you do exercises, the pain rating doesn't go to an 8 out of 10. Maybe it goes to a 6 or a 5 or whatever. But yes, I am a firm believer, which I'll tell you, I was looking up research for Prehab to support that it says it's valuable. And the research is actually conflicted because every Prehab program is different. Some it's just education. Some it's just, let's tell you what equipment needs you have. So they're saying in terms of post-operative outcomes, the research says Prehab is not like the be all end all, but I also think that the Prehab programs they were researching were suboptimal in my opinion. But anyways, all that to be said is I agree with you. I think if the patient does something before, the outcomes afterwards seem to be better.
And I think also meeting your therapist that you're going to be seeing beforehand, and the relationship you form with your therapist, if you hate your therapist, you're not going to do well.
Correct.
And so getting to know somebody, it's just human nature.
It's trust.
I felt it was all very helpful. But we quit doing it because nobody wanted to pay for it.
Correct. I agree. All right. Any other words of wisdom?
I don't know. I don't think so.